Many people don't understand how reimbursements are handled for ophthalmology, and the Mall of Medicine is handled through CMS, but there is a group that the American Medical Association convened many years ago when the relative value scale went into existence that does detailed analyses of various codes, and they try to recommend a value for the code. And it turns out that the AMA RUC recommendations are accepted by CMS about 80 to 90% of the time. And the reason that they're accepted is that it goes through a fairly rigorous process to determine the value of a code. The value of a code is due to a number of factors, and there are three main factors. There is what's called the work, which is the physician work of the particular procedure, and it could be a office-based procedure, it could be a surgery with a 90-day global, or a surgery with a laser with a 10-day global. And so that's the piece of the work component, and that's physician work, it's not staff work. And then there's another component which is just about as important, which is called the practice expense. And in some cases, the practice expense is actually worth more than the work. And this includes a very detailed spreadsheet of information about cost of personnel to screen a patient, arranging for surgery, if it's a surgery, post-operative visits, the cost of personnel for that, the cost of rent. So the practice expense is a very detailed analysis of what it costs to take care of the patient. And then the third component is the liability expense. And for ophthalmology, the liability expense is relatively small, so that's not particularly important. So what the RUC does is that when a particular code comes up for review, and the way the codes come up for review is that they're always looking for what are called misvalued codes. And these are codes where they think that improved efficiency has potentially made the code less time consuming, and hence the value should go down in the view of the RUC. Or it's sometimes that CMS has said, well, we think this code is overvalued, so we want you to review it. So there's a series of screens by what's called the relativity assessment work group of RUC that looks for anomalies in the codes and potentially misvalued codes, and then CMS will also ask for codes to be revalued. So once a code is set up to be revalued, then there is a group from the American Academy of Ophthalmology and American Society of Retina Specialists, and I'm what's called the RUC advisor for the American Society of Retina Specialists, and we send out surveys to members. These are random surveys, and the members respond to the surveys, unfortunately not as many as we would like, but members respond to the surveys, and the time that the members estimate that it takes to do various aspects of the procedure are what goes into what's called our SOR, or Summary of Recommendations. The Summary of Recommendations takes into account the survey results for how much time is involved. Intensity used to matter more, but increasingly what's called intra-service time is the most important thing. And the intra-service time for a surgical procedure is essentially the skin-to-skin time for a procedure. And for a procedure in the office, like let's say the laser, it's how long does it take to actually do the laser. And within the intra-service time, there's also a pre-service time and a post-service time. For example, in a surgical procedure, it may include coming to the operating room, changing, prepping the patient, positioning the patient, and then post-operative work would consist of seeing the patient in the recovery room and then post-operative visits. The post-operative visits are E&M type of visits, and each of the various surgical procedures has a certain number of post-operative visits, and they might be at a level 2, a level 3, or level 4 visit for the post-operative visits. And so those post-operative visits are an important part of the surgical code. So the group of us make a recommendation to the RUC, and the RUC is composed of 31 voting members representing really all of the major specialties. And they use a methodology that they've developed over a number of years to say, well, does this code have an appropriate value compared to other codes? And they compare to other codes within ophthalmology and also codes outside of ophthalmology. For example, they might compare one of our surgical codes to, say, a hernia repair in terms of the time, the intensity. And that's how they arrive at the value. so that everything is relative to one another. And the idea is that physicians should get approximately equal compensation for codes that take about the same amount of time, that have the same complexity, as in the same stress involved to doing a code. And so that's the basis of it, but increasingly intra-service time has become a very key thing. And one of the things that we're limited in is that when the surveys are sent out, we often send out 1,000 surveys between the American Society of Retina Specialists and the American Academy of Ophthalmology for a retina-related code, and we often will get 100 responses back, sometimes even less. And so we're often basing our recommendations on what is potentially a skewed sample, and I think this has sometimes hurt us. And physicians also tend to be optimists. They think of their best cases when they're estimating the time that it takes to repair a retinal detachment, and so they'll say, oh yes, well this particular procedure only takes me 45 minutes or an hour and a quarter, whatever. And so those survey results have sometimes hurt us, and they've resulted for reductions. And over the past 10 years, there have been substantial reductions in the vitrectomy codes like pars plana vitrectomy and epiretinal membrane removal. Also the retinal detachment related codes for repair of retinal detachment with vitrectomy and scleral buckle. The laser codes have also had substantial reductions for doing panretinal laser, focal laser. And similarly, imaging codes such as fluorescein angiography, ICG angiography, OCT have also seen substantial reductions. And so the net effect of all of this is that it has reduced our reimbursement, and as a result of this, as we become more and more efficient at doing things, actually the value of our codes goes down. And so we're very much like a hamster on a wheel, and the faster that we run, the faster the wheel turns. And so these are some of the things that have resulted in reduced reimbursement. Another important issue that's come up over the past really several months is that in April of 2019, the RUC revalued the E&M codes. The E&M codes both for new patients as well as return patients. And the cognitive specialties argued that electronic health records have made them much less efficient in seeing patients. It's taking them lots of extra time. And the net effect of this is that the RUC recommended increased values for the E&M codes, substantial increases in some situations between the practice expense and the work time involved. And as a result of this, the E&M codes go up. Well, in the RUC, the pie, or not the RUC, but in CMS reimbursement, the pie is a fixed piece of pie. And so if one code goes up, then the others go down. So the increase in the E&M codes, which is the most common code that is actually used in all of medicine, an increase in that will mean that we'll have decreases in all of the other codes. And as I mentioned earlier, bundled within the surgical codes are the fact that you have several E&M visits, depending upon what the surgical procedure is. And the RUC had recommended that these new higher values for the E&M codes would be factored into the surgical codes, which would have helped to mitigate some of the loss of value of some of the surgical codes. Unfortunately, Medicare in the preliminary rule decided that they did not want to honor that recommendation from the RUC, and that they in fact wanted to keep the old values for the E&M codes and the surgical codes. And the American Academy of Ophthalmology and the American Society of Retina Specialists and a number of other specialties, including surgical specialties in the AMA, have written letters to CMS complaining about this because we really don't think it's fair to do this. And as you recall, that the RUC is all based on relativity, the relativity of one code. Well, if you don't apply this to the post-operative visits, this actually destroys the relativity of the codes, so it actually turns the entire coding system up on its head.